Hi, I'm Dr. Elizabeth Goetz. I'm an assistant professor of pediatrics at the University of Wisconsin in Madison and director of the Normal Newborn Nursery. I'm also the educational coordinator for the Wisconsin Shine Project. The Wisconsin Shine Project is a statewide effort to implement universal screening for critical congenital heart disease using pulse oximetry. In this video, we will review the basics of screening for critical congenital heart disease using pulse oximetry and demonstrate how to actually do the screening. We'll also review what to do with the results of the screen. Critical congenital heart disease is defined as structural or functional defects in the heart present at the time of birth that result from abnormal development in the heart. Critical congenital heart disease describes those defects that, if left untreated, can cause a baby to become critically ill or even die in the newborn period. About 2.5 of every 1,000 babies born will be affected by critical congenital heart disease. About half of these babies are discovered to have problems with their heart by routine prenatal ultrasound. Of the remaining half, most will be identified after birth by abnormal physical exam. However, a small but very important percent of these babies will have a normal physical exam, normal vital signs, and even be feeding well. In other words, they will appear to be completely normal. Unfortunately, these babies can very quickly become critically ill and even die in the first days of life. Although babies with critical congenital heart disease can look very normal in the immediate newborn period, a common feature of most forms of critical congenital heart disease is lower than normal saturation of the blood with oxygen. Low oxygen saturations can cause a baby to look cyanotic or blue. Unfortunately, babies do not always look blue even when they have abnormal oxygen saturations. It is important to understand that recognizing cyanosis in the newborn can be difficult. A study in 2007 that measured pulse oximetry in the delivery room and asked blinded clinicians to identify when the baby made the transition from looking blue to looking pink found that the average oxygen saturation where a baby was identified as looking pink was 69%. It is best to think about this as a cyanotic blind spot, where oxygen saturation is abnormal, but the baby appears to be pink with no signs that anything is wrong. We can take advantage of the fact that babies with most forms of critical congenital heart disease have abnormal oxygen saturation and use pulse oximetry as a screening tool to identify those babies who look normal and well but have lower than expected oxygen saturations. We know that identifying these babies early and intervening before they become critically ill will lead to much better outcomes for these babies and for their families. Over the last several years, more and more studies have shown that pulse oximetry is an effective mechanism for detecting critical congenital heart disease that would have otherwise been missed. In September 2011, the U.S. Secretary of Health and Human Services recommended that pulse oximetry screening be added to the recommended uniform screening panel. Routine pulse oximetry screening for critical congenital heart disease was endorsed by the American Academy of Pediatrics in December 2011. The goal of the Wisconsin Shine Project is to implement universal screening for critical congenital heart disease using pulse oximetry. This means that all babies born in Wisconsin should be screened. This includes all babies born in the Normal Newborn Nursery or Well Baby Nursery, all babies who are known to have critical congenital heart disease, and all babies born outside the hospital, like in birth centers or at home. Really, the only exception to who should be screened is babies who are admitted to the NICU who require oxygen for pulmonary disease. Babies admitted to the NICU who do not require oxygen for pulmonary disease should also be screened. The ideal time to screen is between 24 and 48 hours of life. If a baby is going to be discharged home before 24 hours, do the screen as close to the time of discharge as possible. Most nurseries find it easiest to couple the pulse oximetry screen with other screens that typically happen between 24 and 48 hours of life, like the newborn blood screen. This is one of the reasons that the Wisconsin Shine Project collects the results of the pulse oximetry screen on the newborn screening blood card. Babies in the NICU that have their pulse oximetry screen deferred due to pulmonary disease should have the screening done when their pulmonary disease resolves. In this case, we recommend photocopying the newborn blood screen card before it's used and setting that copy aside. When the baby's pulmonary disease resolves, the newborn critical congenital heart disease screen can be filled in on the photocopied card and sent to the State Lab of Hygiene. The first step in screening is to gather the necessary equipment. First, you'll need a pulse oximeter and a reusable or disposable probe. It's important when choosing a pulse oximeter that it is motion tolerant and approved by the FDA for use in newborns. It's also important to make sure that the probe you're using is designed by the manufacturer for use with a specific pulse oximeter. The most commonly used pulse oximeter in the Wisconsin Shine project will be the Masimo Rad-5. Other oximeters that meet specifications of being approved for use in neonates and able to provide accurate readings with low perfusion and motion are also acceptable. The Rad-5 is easy to use and runs on AA batteries. Important things to know about this oximeter are the power button, which is circled with green. That will turn it on, and this is going to have some beeping. The signal IQ, which is located on the right side of the screen, is an indication of the quality of the signal and the timing of the pulse. The pulse will also read in the bottom green window, but it's nice to see this bar will go up and down with the pulse. The height of the bar indicates the quality of the signal. So that's another thing to watch while you're obtaining a reading, is make sure that the bar is obtaining a good quality signal, especially if you're waiting for the pulse oximeter reading to raise up into the 90s. The perfusion index is right here on the left side of the pulse oximeter. This is the percent of pulsatile to non-pulsatile signal. The bar is the highest up near the top when the quality of the perfusion site is best. The pulse oximetry reading will read out in this top window in red, and the heart rate will monitor on this in green in the lower window. Other things that are useful to have on hand are blankets for swaddling the baby. A parent or a nurse can be helpful to help soothe the baby during the screen. And it's good to have on hand a place to record the results of the pulse oximetry screening. Ultimately, the results need to be recorded on the newborn screening blood card, but different hospitals will have different places that they want to also record the results. Remember to discuss the screen with the parents before you start. While it's not necessary to obtain informed consent to do the screen, parental education is an important part of this process. It's best to do the screen on a baby who's in a light sleep or quietly awake. Babies who are screaming or really active, or babies who are sleeping deeply, may make the screen more difficult to obtain. When we do the screen, we start out usually in the right hand. We have to get the screen on the right hand and one foot. It's possible to do them at the same time, but it's much easier to do them in sequence. Doing it at the same time may require you to have two sets of equipment. I'll demonstrate the screen using the Masimo Rad-5 since it is the pulse oximeter that most people are going to be using. Our nursery, and in many nurseries in hospitals, we do use a disposable probe. This disposable probe looks like this and comes with a little sticky backing. We found in our nursery that the probe with the longer tail is easiest to use. With the probe, all you would do to use the disposable probe is disconnect whatever other probe is on there and insert the sticker with the yellow bars up on the connecting piece. Then it's as easy as taking the adhesive off the back and attaching it to the baby. So with a baby's hand, they're fortunately small enough that the easiest places to place the probe are on the outside of the hand or on the wrist. The manufacturer guidelines say you can also use a finger, but baby fingers are so little that that can be difficult to do. An important part is to make sure that the red light is placed opposite the sensor on the baby's hand. And then you can just use the tape to wrap that around. Once it's on, you may need to wait for a little while for the pulse oximeter to measure the reading. As I said, this can take a while. And in our nursery, we generally advise waiting at least 1 to 2 minutes before we obtain a reading. Often it can take a little longer. So as we can see, right now we're getting a reading of 84%, but we're not getting a good signal IQ. The perfusion index looks adequate. So in this case, I would just wait and wait for that pulse oximetry probe to start picking up the baby's heart rate. And this is a good demonstration. The probe started off reading 81%, and then with a few minutes of time went right up to 100%. The baby's heart rate is 134, 135 in this window, and we see with the signal IQ we're getting a really good signal, and the perfusion index is also midway up. So that completes the first part of the screening on the right hand. After screening the baby's right hand, the next thing that you need to do is screen either one of the baby's feet. For this demonstration, I'm going to use the reusable oximeter, or the reusable probe, which many people will be using. This is a Y-shaped device with the two probes actually at the ends of the Y. There's 3 different types of probe covers that will come with the reusable probe. One of them is just a simple bar with holes in it, and I'll show you how to use those. Another type is actually an adhesive. The adhesive goes around the baby's hand and also adheses the probes to the baby's hand. And the third type has a clear sticker on the top part that comes down over the probes so that they're not actually touching the baby's skin. So I'll demonstrate with this probe cover, which is the most commonly used one, just a simple band. And all you do is insert the little black buttons into the holes so that I always think of that the sensor goes on the sticky side. And then those will go right in just like that so that it looks just like this on the sticky side of the sensor. Then we'll measure the pulse ox in the baby's foot. So again, I want to make sure that I have the sensors directly against the skin without a lot of extra space in between the sensors and the skin. I initially had a little difficulty with this probe going all the way around the baby's foot. So I switched over to a probe that had a little bit more adhesive backing and was able to get a pulse oximetry reading right away. Again, my pulse oximetry reading started around 78, but after a few minutes of waiting and making sure that there was good signal IQ and a good perfusion index, the pulse oximeter quickly read 100 with a heart rate of 134. One thing to troubleshoot is that if you're getting a low reading for a long time and the heart rate isn't really what you are getting when you listen to the baby, that might be a reason to keep waiting and make sure that the heart rate is reflecting what you know the baby's actual heart rate is. When obtaining the pulse oximetry on the baby, remember that the reading may jump up and down between a narrow range of numbers, say between 96 and 98%. It's okay to use that higher number when you're recording the final result. Also, typically we'd expect the hand reading to be a little bit higher than the reading in the foot, but in experience we know that the foot reading can also sometimes be higher than the hand. It's okay to use the hand and the foot readings as they are. Just remember that if there's more than a 3% difference between the hand and the foot, that would be cause to consider it an abnormal reading. Once you have your pulse oximetry measurement, the first thing it's important to do is record the results on the newborn blood screen card. There will be a section on the blood screen card that will say pulse ox screening, and you'll have the choice of either checking the box pass, fail, or not screened. Remember, if you're checking not screened, you should have made a photocopy of the newborn blood screen card and set that aside. Those will be the babies who are having an oxygen need due to pulmonary disease. And you can fill in the results on the photocopy of the newborn blood screen card after the baby's disease has resolved or when the baby is getting ready to go home from the NICU, even if they are still having a small oxygen requirement. Now you're ready to interpret the results. One of the key things I like to remember when interpreting the results is the idea of 2 sites, 3 strikes. 2 sites refers to the 2 sites that we got the measurements from, the right hand and either foot. The 3 strikes refers to the fact that the baby has 3 chances to pass the screen. With the initial screening test, babies can pass, fail, or need a repeat screen. The vast majority of babies will pass this test on the first screen and require no further screening. To pass, a baby must have a pulse oximetry reading, or an oxygen saturation, of greater than or equal to 95% in the hand or the foot, and have less than 3% difference between the hand and the foot. The foot may be higher than the hand, which is okay, as long as the difference is never greater than 3%. If the baby meets these criteria, they pass and need no further screening. A baby will immediately fail the screen if the oxygen saturation is less than 90% in the hand or the foot. If the baby fails the screen, the medical care provider should immediately evaluate the baby. If a baby has an oxygen saturation 90 to 94% in the hand and the foot, or there is greater than 3% difference in saturation between the hand and the foot, they fall right in that gray zone between pass and fail. And in these babies, we repeat the screen in 1 hour. On the second screen, the baby can either pass or fail, just like in the initial screen, or fall into that middle zone again with saturations between 90 and 94% or greater than 3% difference between the hand and the foot. In these babies, the screening test can be repeated a third and final time. On the final screen, the baby can again pass or fail, but if they fall in the middle zone with saturations between 90 and 94% or greater than 3% difference between the hand and the foot, for a third time, it's considered a fail. Newborns who pass the screen at any time are done and require no further screening. Newborns who fail the screen should be clinically evaluated for critical congenital heart disease and also other diseases like respiratory distress or other pulmonary diseases, and most importantly, sepsis. Critical congenital heart disease is usually diagnosed with an echocardiogram. The baby's primary care provider can work with pediatric cardiology to determine the best management plans for the baby. An important part of the Wisconsin SHINE project is evaluating the effectiveness of pulse oximetry screening for critical congenital heart disease. A database similar to the database used to track the results of hearing screens has been created and is called We Track Heart. Information on babies with critical congenital heart disease who are identified through prenatal ultrasound, physical exam, or pulse oximetry screening will also become part of the Wisconsin Birth Defects Registry. Creating this database and using the registry will help provide better services and interventions for newborns in Wisconsin. Reporting the results of pulse oximetry screening is easy. The results should be filled in the designated space at the bottom of the newborn blood card. The results will be entered into We Track Heart at the State Lab of Hygiene. When a baby passes their pulse oximetry screening, all you need to do is check Pass on the blood card. Remember, there will also be an option to check Fail and Not Screened. There are 4 circumstances when we would ask you to call the Wisconsin SHINE project to provide additional information. There is no blood card available to report the pulse oximetry screening results. The baby fails the pulse oximetry screen, or the baby is known to have or suspected to have critical congenital heart disease by prenatal ultrasound or by physical exam prior to the pulse oximetry screening.